start the
Yes,
class.
yes, yes. Yes, sir. Good evening, everyone. Today, the topic for discussion would be metabolic response to surgery by Dr. Samir.
Samir, you can
Samir, you
start.
can start.
Hello. Yes. Ma'am, am I audible? Hello.
Hello.
Ma'am, am I audible?
Yeah, little not very clear.
Are you on a Wi-Fi or this one? Where are you?
Wi-Fi. Wi-Fi, sir.
Why is it like there is a lot of disturbance?
Hello. Is it
Uh,
better, sir?
yeah, better now.
Okay.
Okay.
Yes. Uh, so we'll be discussing on metabolic response to surgery. So
Go
these are
on.
the yes, sir. Good. So these are the table of contents. We'll be going through the implications of surgery, the metabolic response, surgical stress, how to reduce the surgical stress, and recent advancements. Coming to the implication of surgery, to give a picture on surgical mortality, around close to 30 million surgeries are performed in India per year, and the mortality during surgery is relatively rare. From the Western countries, it is about 1 to 4%, and in India, it is about 2.4%, according to literature and studies. And the
Samir,
number
one
is
second. Ravi Shankar sir has joined. Good evening, sir.
good evening. Good evening, sir.
Sir, good evening. ಸ್ವಲ್ಪ ಟೂತ್ ಏಕ್ ಇದೆ ಆಪ್ಸಸ್ ತರ ಆಗಿದೆ ಸೊ ಐ ಕಾಂಟ್ ಸ್ಪೀಕ್ ಮಚ್ ಸೊ ಐ ವಾಸ್ ತಾನಿಯಾ ಟು ಮಾಡರೇಟ್.
ಅಲ್ಲ ಇದು ಟ್ರೀಟ್ಮೆಂಟ್ ತಗೊಳ್ಳಿಲ್ವಾ?
ಇಲ್ಲ, ರೂಟ್ ಕೆನಾಲ್ ಮಾಡ್ಬೇಕು ಇವತ್ತು. ಶೀಸಾ ನಾಳೆ ಮಾಡ್ತೀನಿ ಅಂತ ಹೇಳಿದಾರೆ. ಶೀಸ್ ಓಪನ್ ಅಪ್ ಮಾಡ್ಬೇಕಂತ.
ಆಂಟಿಬಯೋಟಿಕ್ ತಗೊಳ್ತಾ ಇದೀಯಾ?
ಕ್ಯಾವಿಟಿ ಫಿಲ್ ಮಾಡ್ಸಿದ್ದೆ, ಆಂಟಿಬಯೋಟಿಕ್ ತೊಗೊಂತಿದ್ದೀನಿ. ಕ್ಯಾವಿಟಿ ಫಿಲ್ ವರ್ಕ್ ಆಗ್ಲಿಲ್ಲ ಅಂತ ಅಂದ್ರೆ ಶಿ ಸೆಡ್ ಶಿ ವಿಲ್ ಡೂ ರೂಟ್ ಕೆನಾಲ್ ಅಂತ. ದಟ್ ಡಸಂಟ್ ಸೀಮ್ಸ್ ಟು ಹ್ಯಾವ್ ನಾಟ್ ವರ್ಕ್ಡ್ ಅದು. ಸೊ ಫುಲ್ ಸ್ವಲ್ಪ ಆಪ್ಸಿಸ್ ತರ ಆಗಿದೆ ಅಲ್ಲಿ.
ಎಲ್ಲಿ ತೋರಿಸ್ತಿದ್ಯಾ?
ಇಲ್ಲೇ ದಿಕ್ಕಿ
ಹಾ
ಅದಕ್ಕೆ ಮಾಡ್ತಾ ಇರೋದು.
ಅಲ್ಲ, ರೂಟ್ ಕೆನಾಲ್ ಡಾಕ್ಟರ್ ಕಾಮತ್ ಅಂತ
ವಿಲ್ ಸ್ಟಾರ್ಟ್ ಅಂತ
ಗಿರೀಶ್ ರಾವ್ ಕ್ಲಿನಿಕ್
ಎಲ್ಲಿ?
ಬರ್ತಾರೆ. ಅವ್ರ ಹತ್ರ ಗಿರೀಶ್ ರಾವ್ ಕ್ಲಿನಿಕ್ ಅಲ್ಲಿ ಡಾಕ್ಟರ್ ಕಾಮತ್ ಅಂತ ಬರ್ತಾರೆ. ಇಸ್ ವೆರಿ
ಓಕೆ
ಗುಡ್.
ಓಕೆ
ಒನ್ ಸ್ಟೇಜ್ ಮಾಡ್ತಾರೆ,
ಓಕೆ.
ಅಲ್ಲಿಗೆ ತೋರಿಸ್ಬಿಡು. ಬೇಕಾದ್ರೆ ನಿಂಗೆ ಗೊತ್ತಲ್ಲ ಗಿರೀಶ್, ನಾನು ಗಿರೀಶ್ ಹತ್ರ ಮಾತಾಡ್ತೀನಿ ಬೇಕಾದ್ರೆ.
ಅಲ್ಲಲ್ಲ, ಅಲ್ಲೇ ಹೇಳ್ಬಿಟ್ಟಿದ್ದೀನಿ ದಿಕ್ಕಿತಾಗೆ. ಶಿ ವಿಲ್ ಫೀಲ್ ಬ್ಯಾಡ್.
ಅಲ್ಲ, ದಿಕ್ಕಿತಾನೆ ಮಾಡ್ತಾಳಂತ ರೂಟ್ ಕೆನಾಲ್.
ಶಿ ವಿಲ್ ಓನ್ಲಿ ಡೂ. ಮಾಡ್ಸಿದೀನಿ ಪ್ರೀವಿಯಸ್ಲಿ.
ಓಕೆ, ಸರಿ, ಹಂಗಾದ್ರೆ ಸರಿ. ಓಕೆ, ಸರಿ ಸರಿ,
ಓಕೆ
ಹಂಗಾದ್ರೆ
ಓಕೆ.
ಹಾ, ಕ್ಯಾರಿ ಆನ್.
Yes,
So
sir.
Samir has just started ಇವಾಗ mortality. Start off Samir again.
Yes, sir. So, to give a picture on surgical mortality, around close to 30 million surgeries are performed per year in India alone, and the mortality rate during surgery is relatively rare. It's about 1 to 4%, less in the Western countries, and comparing India, it's about 2.4% mortality rate according to literature and studies, and the number is increasing by almost 400,000 per year worldwide.
Samir, is it
Um,
perioperative or intraoperative mortality which you're talking about? You're not clear.
Sir, after the major surgeries, this is the
That is, see, usually all mortality figures are quoted up to 30 days after surgery. So that is considered as perioperative mortality. That is what most figures quote. Okay, you should know that.
yes, sir. Yes, sir.
Because intraoperative mortality is a different thing altogether.
No, sir. This is like mortality after major surgery up to 30 days.
Perioperative, it is called
Yes, sir.
perioperative mortality, which is up to 30 days after surgery. Okay,
Yeah.
carry on.
Yes, sir. And equally challenging entity is the surgical morbidity. About 14.4% of patients will experience adverse events, and almost 50% of these events can be preventable. Reducing these events will decrease the hospital stay, need for ICU admission, readmissions, and surgical site infections. So the metabolic response, to define it, it is the acute response to one or more breaches of body's barrier function from sterile injury, which we can see over here. It occurs due to incision, manipulation, excision, and pain. and pathogen invasion and gut bacteria translocation. So it starts from the induction of anesthesia, and due to the sympathetic discharge from the induction of anesthesia, the autonomic imbalance will start and will cause the leaky blood-brain barriers, endothelial dysfunction, mitochondrial dysfunction, and gut wall ischemia. This will lead to the difference, the alteration in coagulation, modified immune regulation, increasing susceptibility to infection, and reduced tissue oxygen. Further, it will cause cardiac injuries and liver failures and widespread organ dysfunction. Uh, Sorry. The wave starts from the induction of anesthesia, and the end point cannot be defined and is dependent on the type of surgery, the duration of surgery, the medication profile on what the patient is on, and a number of earlier surgeries. The Coming to the history of surgical stress, in
Amir, anything
1870,
related to patient's age or gender, does that affect, has any effect on the surgical stress?
yes, when geriatric and it there is a difference from.
No, various factors you said, type and duration of surgery, no? Other than that,
Yes.
other than surgery, anything else related to patient factors that affects the surgical stress?
There are innumerable factors, but as such age, geriatric population will have a different response to stress.
No, I
Okay.
think,
What about?
yeah, others, you ask others, Sanya.
Yeah, yes, sir. Praveen, any other factors that have an effect on surgical stress?
Yes, sir. Patient nutrition condition.
Like?
ಎಲ್ಲ risk
Comorbidities.
Yeah, comorbidities. You can divide it into patient factors, operative factors, and post-operative factors. Patient like being age, sometimes gender, obese, if the patient is obese or not, general habitus of the patient, and comorbidities. Interop depending on the type of surgery and the duration of surgery, or if any event that happens during surgery will also have a surgical stress on the patient. Post-op, depending on the patient's recovery, how patient recovers and how the hemostasis is maintained, that also will have an effect on the patient.
To stress on the role of age, I think the extremes of ages, the immune
Yes, sir.
responses are less. So that is why they say children are similar to grandfathers and grandmothers, because I think, for example, an appendicitis in a very young child, the peritonitis and the response to peritonitis will be very different compared to a normal child at say, let us say 5 to 15 years of age. And similarly 80 years and above, I think the for even with the perforated appendix, the immune response to that will be much less. So you have to factor these in when you are assessing the patient. So the stress response to in the extremes of ages is different. Other thing is, as they said about comorbidities, you have to talk especially about diabetes, where the not only does response to immune uh, the immune factors and infection and stress and trauma, bleeding is much less, the response is attenuated, and also insulin resistance becomes a major issue in diabetics. Though insulin resistance is there in everybody, it is much more of an issue in diabetics. And if the diabetes is there for a long period of time, autonomic neuropathy exists, and that also has an effect on how the patient responds to stress. So there will be autonomic neuropathy. So the stress response to any trauma or bleeding or surgery will be much less. So diabetics especially are more prone to these kind of variations. So I think what Sania listed is correct. In addition, you should know why you have to be more careful with the diabetics and in the extremes of ages. Okay, carry on.
So, coming to the history of surgical stress, in 1877, Claude Bernard he termed the milieu anterior, which literally translates to the stability of organism and its internal environment, which gave the basis of homeostasis. And then Walter B. Cannon described the stress as a challenge to body's homeostasis and the adrenal gland's role in management of the stress. This led to the concept of flight or flight. And then Sale distinguished the acute stress from chronic stress, and he also described the neurological stress of patients during anesthesia, which led to the division of psychogenic stress from the surgical stress. Sale also divided the surgical stress into alarm phase, resistance phase, and burnout phase. Finally, David Cuthbertson, he characterized the complex stress response into the early ebb and late flow phase. So the ebb phase begins 2 hours post surgical insult, lasting up to 24 to 48 hours. It is characterized by glucose intolerance, decreased cardiac function, decreased tissue perfusion, and decreased basal metabolic rate and hypothermia. And then the flow phase starts, where the body slowly builds up the basal metabolic rate, increases the cardiac function. There is increased blood glucose, and there will be increased muscle wasting. This can last up to few days. Now, coming to the progression of response from central nervous system level, due to the activation of hypothalamic pituitary adrenal axis, there will be production of adrenocorticotropic hormone, which will cause the stimulation of cortisol. Cortisol is the major hormone associated with surgical stress. And further, the growth hormone will stimulate glycogenolysis, lipolysis, and protein breakdown, which is crucial in the management of surgical stress. Also, thyroid T3, T4 will stimulate oxygen consumption by tissues after surgery. The other axis controlling the surgical stress is the nucleus tractus solitarius axis, the NTS axis. The NTS axis regulates blood pressure, cardiorespiratory functions, inflammation, immune function, and metabolism. Due to the higher sympathetic shift after the surgery, there can be imbalances, which once if they are not controlled, will lead to imbalance in the functions of nucleus tractus solitarius axis. Going to the tissue level response. Once there is damage, release of damage associated molecular patterns, they will be sensed by the nod and toll like receptors, which will activate the innate immunity in the patients, and it will lead to release of pro-inflammatory cytokines. These are IL-1, interleukin 1, 6, and TNF alpha, which will again activate the hypothalamic pituitary axis, and this cascade will go on repeating. And this cascade is inflammatory, and once it is over-regulated, it will form the basis of clinically detectable systemic inflammatory response syndrome. Systemic inflammatory response syndrome, once it is uncontrolled, will lead to multiple organ dysfunction syndrome. And there is also the other side of picture, which happens in patients, where there can be upregulation of anti-inflammatory cytokines, leading to the release of TNF SR, the TNF 55, 75, and interleukin 1 RA, and cytokines which are IL 4, 5, 9, 13, and TGF beta. This will limit the inflammatory response in the patients and can cause uncontrolled sepsis and tissue destruction.
Samir, how do you define a systemic inflammatory response syndrome? There's a standard definition for systemic inflammatory response syndrome. Define that.
It is defined by three things. Can be hypothermia or hyperthermia, and the
Okay.
heart rate more than 90, and tachypnea more than 20. Also, WBC counts either more
It
than
is not
12 into.
tachypnea, respiratory rate, respiratory rate. Tachypnea cannot be more than 20.
Yes, sir. Respiratory rate more than 20. White cell count more than 12 into 10 to the power 9 or less than 4 into 10 to the power 9.
Okay.
What is mods then?
Modes will be the sepsis with damage to one or more organs like brain, heart, cardiac functions.
It is
And how is
dysfunction.
sepsis different?
Mods
Sepsis,
are failure. There is the difference between organ failure and mods.
se- sepsis will be the systemic inflammatory response syndrome with a documented infection, and
Okay.
modes will be sepsis with damage to one or more organs of the
No,
body.
what you have to say is reversible damage. That is MODS.
Yes, sir. Hmm.
So
That
if
is
it
what I
is
was asking.
if it is irreversible, then it becomes failure, organ failure.
Okay. Yes.
Okay, and sepsis need not be. It can be SARS, and also it need not be. It can be due to some other thing also. Mods can happen. Shock can. It's not like sepsis has to be there, sir.
Yeah. Mods can happen due to volemia due to severe vomiting and diarrhea, or trauma with significant blood loss, or even spinal shock. When there is spinal shock, because of the attenuated the autonomic response, they can go into state of shock, and then that can lead to MODS also. So sepsis is one cause for MODS. There can be many other causes.
Sir.
Carry on.
Yes, sir.
You're doing well so far. Come on.
Yes.
Yeah. Go on,
So,
Samir.
this is the endocrine response to surgery, which I have described. And this is the pictorial representation. So there will be the decreased thyroid hormones after surgery, and also all these cytokines which increase, and improper regulation of insulin. We'll deal with it in the next slides. Coming to the
So actually, this is why
yes,
I have seen many physicians ask for T3, T4, TSH in the acute phase when the patient is in the hospital ICU and unwell. It is useless because you will always get wrong values. So don't ask for thyroid function test when the patient is sick. So you only ask for it once the patient is recovered from it to assess the exact thyroid function if you want to treat them later. Okay, carry on.
yes, sir. Coming to the carbohydrates, the cortisol and catecholamine will cause the increased hepatic glucose metabolism, and depending on the surgical intensity, the glucose level will fluctuate. And the insulin plays a major role in surgical stress, wherein there will be hyperglycemia, which can persist up to weeks, and because of peripheral resistance, the insulin levels will increase, and all these complications will cause increased wound infection and impaired healing in patients.
Samir, you
Yes, sir.
can't have these kind of spelling mistakes. You have got two or three spelling mistakes in the same resistance, cause. So I
Yes,
think you should
sorry, sir.
check on all these things. These are basic things we shouldn't be mentioning these things at all.
Sorry, sir.
Okay, carry on.
As of for the protein, the cortisol and growth hormone causes skeletal muscle breakdown, and amino acids, ketone bodies, and the acute phase proteins will increase in body, and there will be increased nitrogen excretion in the body, which will lead to weight loss and muscle wasting.
Samir, acute phase reactants, uh, it can't raise. There are two types of acute phase proteins. Can you name them? There are something like positive and negative.
Yes, ma'am.
Huh.
So the positive acute phase reactants are CRP, mannose binding protein, hepatoglobin, ferritin, alpha-1 antitrypsin, and complements.
Okay, what
And
happens to them in injury or any stress response?
uh, increases they get because they're positive, and they get increased.
They increase.
And
What about the negative
and
ones?
negative will have this transferrin, antithrombin, albumin,
Important one is and
albumin,
that's why
and yeah.
in inflammation, albumin will be in kind of stress response, albumin will be low. So that's why, like how sir taught us in nutrition, albumin, more than albumin, pre-albumin is a better indicator for nutritional status because albumin tends to decrease during an inflammatory response.
Yes.
Okay. Yeah.
As of for the lipids, the cortisol, catecholamines, and growth hormone will cause increased lipolysis. But the triglycerides, glycerol, and fatty acids are not markedly increased, according to studies. And insulin plays a important role in inhibition of lipolysis, and there will be increased ketone body formation in the patients after surgery. As of for water and
Go back,
electrolyte
Samir.
balance, yeah.
Go back for this thing. Here, uh, yeah, fat. Here you're telling growth hormone causes increased lipolysis. Then you're telling insulin causes inhibition of lipolysis. Can you explain that?
Um, Insulin will
Yeah, the
Answer,
sequel of
answer.
response.
If you know or if you don't know, don't keep on like staying silent. Otherwise, we'll move on to the next person. She will ask next person.
insulin causes the inhibition of lipolysis.
Yeah, but your
They,
growth hormone is causing increased lipolysis. So will lipolysis be will not happen? Like it will be neutral as a normal lipolysis happening.
yes, but because both of these are contraindicated, that's why the levels of fatty acids are not increased.
But how did ketone body formation increase then?
Anybody else answer this, please?
Insulin resistance and insulins will be low in inflammation, sir. So there
Yeah,
will be
yes. More of lipolysis happening.
lipolysis.
Peripheral resistance.
No, not only that, you're right, but not only that. See, as I keep telling you, thyroid hormones, growth hormone, the corticosteroids, ACTH, the catecholamines, glucagon, all of these things have a role like they will increase the glycogenolysis muscle and dissolution or destruction of muscle protein and also lipolysis. So their purpose is to increase the energy, the energy into the body into the system. Insulin is the only one which is fighting this, and in addition there is insulin resistance. So hence there will be increased lipolysis as a because insulin cannot fight so many of them all the time, especially in the
Yes, sir.
post-operative status because there is also peripheral insulin resistance also. So that
Yes, sir.
is what
Yes.
she was trying to find out from you. Okay, carry on.
As of for the water and electrolyte balance, the arginine, vasopressin, and renin-angiotensin system will act on retaining water, and depending on the severity of surgery, there will be water retention, which will lead to edema and kidney injury. This will also cause impaired healing in patients.
So what do you have to do to go back to that slide?
Yes.
So what happens? Renin-angiotensin, vasopressin. How long does the vasopressin rise happen? Is it elevated forever or is it temporary?
It is only for 3 to 5 days, sir.
Who said that?
Me, sir, Sanya.
Tanya. Okay. Anybody else want to differ from that?
Sir, 24 to 48 hours.
Correct. It is usually the effect is very pronounced in the first 24 hours. It will start tapering down by 48 hours, which is why the fluid requirements of the patient is, that is why we keep on stressing on obligatory fluid restriction. So previously the anesthetist would put up a bag and either they used to look at the newspaper or the mobile phone and tell the operator technician to put the next bag up without realizing, the bag keeps on going up and up and up. So by the time 3-hour surgery is done, 3.5-4 liters of fluid is given. So that is over hydration, which is not required. So now you have to what is called as goal directed therapy, where if you have monitoring facilities, the ideal monitoring is the transesophageal, especially in patients who are extremely volatile and patients who are unstable surgically. Such patients, transesophageal Doppler. If the facility is not available, have a central line and blood pressure monitoring, continuous blood pressure monitoring, and give fluids accordingly to maintain the blood pressure and the pulse rate. And the fluid should be obligatorily restricted for this reason, because the renin-angiotensin mechanism is working over time, which will cause sodium retention also and loss of potassium in the kidney. So in the distal convoluted tubule, the renin-angiotensin aldosterone mechanism will, what shall we say, retain sodium in lieu of potassium and also hydrogen ions. So because of that, there will be significant amount of fluid retention because sodium will attract water along with it. And hence you have to be careful giving too much fluid in the first 24 to 48 hours. So this is the purpose of knowing this sequelative response. There is no point knowing something unless you know the implications in the post-operative or perioperative management of the patient. Okay, carry on.
So the avoidable factors in management of surgical stress will be hypovolemia, hypothermia, edema, and starvation and immobility. Volume loss can be managed by maintenance of IV fluids and reducing excessive infusion of fluids. Hypothermia as such can be managed by heat covers and maintaining normothermia throughout the surgery.
How do you do
Edema,
that? How do you do that? How do you maintain hypothermia? Which are the patients who are more prone to developing hypothermia? Come on, man. What is the triad in patients? Anybody else?
Pediatric patients, sir.
Huh?
Pediatric patients.
Correct. Pediatric patients, they are prone to hypothermia, right? Who else? Nikita?
So very
Aina?
thin and emaciated patient, sir.
Yeah, maybe, but
Yes, low BM.
not so much. Aina?
Malnourished patients are like
Maybe
undernourished.
malnourished patients. No, think more in surgical patients, man. Malnourished, yeah, they can, but not so much because the malnourishment is not sudden. It's not happened, over 24 hours. What is
Trauma with
what?
ongoing blood loss, sir.
Trauma, blood loss. That those people, and who else?
Any major
Elderly.
surgeries, surgical duration which is more than
Yeah,
3 hours.
long duration. But more than that,
There,
burns and patients with sepsis, severe systemic sepsis, patients who have had burns, patients who had significant trauma with blood loss. And so these are the patients you should be extremely careful. So how do you avoid hypothermia, Samir?
sir, the heat covers
No, they
upper
are called. No,
body.
they are not called heat covers. What are they called? What are they called? Hot blankets. So the electrical hot blankets are there, and otherwise also infusion of warm
Warm.
fluids.
Warm
Don't
fluids.
give them don't give them fluids that are there. You have to warm them up to about 37, 38 degrees and infuse that. So infusion of warm fluids and then heat blankets. And edema. Can anyone tell me what are the effects of edema on the body in the post-operative period?
Sir, because of the capillary leak, there will be impairment in renal function and also decreased alveolar diffusion of oxygen.
Correct. That is one. So if there is edema, you can have decreased diffusion of carbon dioxide and oxygen. So that is one. Second thing, what will happen?
AIT, absorption and paralytic ileum.
Correct. So edema of the abdominal, of the gut, there will be paralytic ileus because there is excessive fluid. So the wall becomes edematous. Right. What else? If there is edema in the lower limbs, because the limbs become tight, the patient will find it difficult to walk. So mobility will be, impaired because of the edema. So that is why it is important to, that is why they stressed on obligatory underhydration. We have given you the biochemical and the hormonal, reasoning behind it, and also the effect what it can have over the post-operative status. So knowing both these things, the cause and effect, you should strive to reduce the amount of fluid you give in the immediate perioperative and post-operative period. Not just write something and go. Think about how much the patient needs and everything and give it accordingly. Okay, carry on.
Yes. So to cope up with all these factors, um, the ERAS protocol came into view. The ERAS protocol can be divided into preoperative, intraoperative, and
Samir,
postoperative. Yes, sir.
what is ERAS?
Enhanced recovery after surgery, sir.
Okay, correct. So where did it come into this one first? In what surgery? And who was the person who brought designed it in the beginning? It was in colorectal.
Henrik
Henrik Callet,
Henrik
Professor
Callet.
Professor Henrik Callet,
from
and in
Copenhagen,
colorectal surgery.
Yes, sir.
Okay.
Ersta Hospital in Copenhagen. So that he is the one who did it. I had the good fortune of listening for the first time ERAS protocol being presented to the world in 2004 colorectal congress in Birmingham. So Henry Kellett has changed the face of surgery by this protocol. Okay, talk about it.
Yes, sir. So preoperatively, counseling, pre-admission counseling, fluid and carbohydrate loading, no decreasing the prolonged fasting, selective bowel preparation, antibiotic prophylaxis, and also thromboprophylaxis. While intraoperatively, the ERAS protocol stress on short-acting anesthetic agents, epidural anesthesia, avoidance of salt and water overload, and maintenance of normothermia. And post-operatively, the epidural analgesia, prevention of nausea, vomiting, again the evidence of salt and water overload, and early mobilization, which will then cause this, which will avoid the muscle wasting and due to immobility. So,
Good.
yes, sir. ERAS protocol is, will be dealt in further sections by my HOD sir. So I won't go in details into it.
Yeah, sure, no problem.
Yes, sir. Yes. So this is a Canon's insight to reduce the reduce the surgical stress. Canon thought to start it from the CNS level, wherein he wanted to prevent the overdrive, target the hypothalamic, pituitary and adrenal, and also the nucleus tractus ultraris axis, and also to shift the autonomic balance. So herein we have the three components, which is the loss of central nervous system and cardiovascular system coupling, decreasing the damage to the endothelial glycocalyx system, and maintaining the mitochondrial integrity. So the coupling between the central nervous system and cardiovascular system can be derived by the ratio of left ventricular elastance and the arterial elastance, which can be derived in routine echocardiography. This is the measurement of left ventricular systolic performance, like how it pumps blood, and how the body's arterial conduit will receive the blood. Any impairment causes hyperinflammation, coagulopathy, and immune dysfunction, and also causes the gut microbial change due to mesenteric ischemia. Then going to the endothelial glycocalyx system, this is the nexus between the blood circulation and tissues. It is thought that it is a 50,000 meter square of surface area of glycocalyx, which is spread throughout the endothelium. And because of the decoupling of central CBS and CNS system, which we studied earlier, there will be shedding of glycocalyx and the endothelial system will get activated. Activated endothelium can cause widespread inflammation, loss of vascular tone, and platelet dysfunction, and is triggered by the trauma to tissues which occurs during the surgery, hyperinflammation, and oxidative stress. Uh, in animal models, recombinant non-fucosylated antithrombin was used, which is a newly studied drug which showed decreased glycocalyx shedding. Finally,
Samir,
to the
talking about endothelial glycocalyx and endothelial shedding, what is the basic triad that you know that you have studied in pathology about endothelial damage, which is very important? What is the triad, and tell me
Burgos
the
triad,
ah,
Burgos
what are the
triad,
components
which
of
is the
endothelial?
hypercoagulability, stasis, and endothelial injury. The triad.
Okay. Okay.
Coming to the final component of this, the mitochondrial integrity. As we know, the mitochondria is highly prone to hypoperfusion injuries, and from the oxidative state, the change to redox state will begin after the mitochondrial injury occurs. This will cause the increased lactate production, decreased proton pumping, and the membrane potential will collapse, and this will lead to the formation of damage associated molecular patterns, which we have discussed earlier, and causing tissue damage and oxidative stress. Currently, there are no drugs which can target this, And prevention of hypoperfusion remains the main modality to maintain the mitochondrial integrity. Finally, we'll come to the recent advancements. Various studies have been conducted worldwide and which have shown benefits of aspirin, angiotensin convertase enzyme inhibitors, and also statins. But studies are not yet promising. In 2017 and 2018, there were animal models. In 2018, it was introduced in US Army, the ALM therapy, which is the adenosine, lidocaine, and magnesium, which showed positive results. The ALM therapy reduces CNS stress response and causes a shift in the autonomic response, and also transfers the oxygen to mitochondria. This was the Canon's insight how to reduce the surgical stress. But on translation to human models, there was high failure rate, and there were adverse events in post-market trial. So future translations to human models with proper safety is needed to validate the animal studies. Thank you.
Samir, tell me what exactly is the take-home message from your entire presentation? Like if you have to summarize into just 3, 4 points, what is the salient thing that you carry forward from this discussion?
Yes, ma'am. So we should know how the body responds to the stress of surgery, and how it can be reduced, and incorporating the ERAS protocol so that we can avoid the factors which are causing the surgical stress.
And also post-operative, how you post-operatively monitor so that they get a quicker recovery and it will reduce the hospital stay.
Hospital stay, yes.
Sanya,
Sir,
you have any questions to ask, or you can ask
No,
others
sir.
also any questions?
No questions my side, sir. If anybody else has any questions.
Sir, your comments on the presentation?
So I think Samir, you did well. It is a slightly difficult topic to understand and speak about fluently, which I think you managed. And the slides were good, and you didn't just parrot whatever was there in the slide, but you were trying to explain it, which is good. I think that is the way it should be done. So that is a good thing. Um, Still, a bit more in-depth analysis would have been better. And I think you believed in the principle that everybody's concentration lasts for 40 minutes. So you finished in 40 to 45 minutes. I think this class could have gone on for another 15 minutes if you had gone in a bit more depth, but I think it's okay. I think you can be forgiven because it's a first year, so understanding of the subject is a bit more difficult, but I think you're on the right track. I think that is my
I
comment.
think, yes, sir. I think he has presented a lot better compared to earlier times, and his slides are also a lot better. Sanya, your final comments and this one.
Yes, sir.
Concluding.
Yes, sir. He did really well, sir. Depending, like he's covered most of it, which is really important to know during and in the perioperative period.
See, I think I think take home message Nitya asked for. See, for the students, the take home message is understanding the physiology and pathology is one part of it. But then application of this knowledge and understanding to day-to-day patient management is extremely important. So I think this is what is actually called the real practice of evidence-based medicine. You can't study all these things and go and write 4 liters of fluid tomorrow. You have to be careful about what you write and how much antibiotics when should be given. All of these things. The entire ERAS protocol, I listened to it when Professor Kellett was presenting. It was a lecture for 2 hours. in the main plenary session, and each component of the ERAS protocol, he had data from studies. For example, nasogastric tube. So passing patients with nasogastric tube and patients without nasogastric tube. So though it is difficult to make a multivariate or univariate analysis of all the factors that come into play in the perioperative and post-operative period, he managed to show the difference between each of these components. So I think the status quo for us should be, we do not pass nasogastric tube if not required. If it is already passed, it is to be removed immediately in the in the post, just immediately following surgery, or at least in the first 24 hours. So these kind of things, everything, catheter, mobilizing the patient, giving them good analgesia, early feeding, all of these things will have, as we said, the insulin resistance can last anywhere between 48 to 72 hours, majority, especially if the laparoscopic surgery is less compared to open surgery, but it can last up to 6 weeks. So you have to do everything in your power to try and reduce insulin resistance, so that insulin will help you to recover the patient faster. So knowing the physiology, knowing the pathology is very important, is very crucial, but application of this knowledge to day-to-day patient management is even more important. I think that is the take-home message as far as I am concerned. Niranjan?
Yes, sir. Agree. I agree totally. I think if there are no more questions or comments, I think we will conclude.
Yeah, thank you. Samir, you did well.
Thank you.
Thank you, Samir. Presented well.
Thank you.
Thank you, sir.
Thank you. Good night.